Welcome, fellow practitioners, to the deep dive. Today we're cutting through the noise to get really well informed on a topic that's, well, actively reshaping our approach in obstetrics. How we can optimize maternal recovery after cesarean delivery. We're diving into a pretty pivotal review paper. It not only lays out the roadmap for enhanced recovery after cesarean, or ERC, but it also critically spotlights where our evidence base is surprisingly thin and where we as anesthesiologists can really make the biggest strides.
That's right. Our source for this deep dive is Optimizing Maternal Recovery, Insights into Enhanced Recovery After Cesarean Delivery by Hyosuk Na. And like you said, it's a comprehensive review paper pulling together a wide range of studies. Our mission today, extract the most important insights, highlight areas where our contributions as anesthesiologists are most impactful, and crucially identify where more dedicated research is just urgently needed to, strengthen our evidence-based practices.
What's really fascinating here is how the concept of enhanced recovery after surgery, ERS, which many of us are quite familiar with from other surgical fields, how it's now being meticulously adapted for cesarean deliveries, becoming ERA. This isn't just a simple name change, is it? What makes ERA distinct, really, beyond just the obvious patient population?
That's an excellent question, and it's a crucial distinction. Unlike traditional ERS, which often targets, say, elderly patients with multiple comorbidities, higher risks, ERAs focuses on a population of relatively young and healthy women. But the core difference, the true differentiator, is its dual focus, optimizing both maternal recovery and neonatal well-being. That dual mandate, well, it adds layers of complexity, unique considerations that we don't typically encounter in other ERS protocols. Every single intervention we consider, it has to be weighed for its impact on two patients, not just one.
Right, that dual focus is key. So with that in mind, let's unpack this paper phase by phase, starting with the antenatal and preoperative period. What are the key recommendations the paper highlights for ERAC? And maybe more importantly, what does the evidence, or sometimes the lack of it, tell us about these recommendations?
Okay, so the paper highlights several crucial components, some with actually surprisingly low evidence despite strong, sort of intuitive recommendations. For instance, providing detailed information and education to mothers, about the C-section, what the newborn experience is. That's strongly recommended. But here's a fascinating insight, the evidence level for this. Currently rated very low to low. The rationale is that well-informed mothers are likely to understand things better, which facilitates faster recovery, maybe even shortens hospital stays. The nugget here isn't questioning its value, but acknowledging the gaping hole in rigorous data for something so fundamental. It pushes us to think about how we might better show its tangible impact. And from our perspective, this patient engagement before surgery, it can also significantly ease anxiety, which, well, we know is always beneficial. We also see strong recommendations for no sedative premedication, primarily due to potential placental transfer effects on the neonate, which aligns perfectly with what we already prioritize in OB anesthesia, so that's a welcome reinforcement.
Okay, and what about the practical prep? Things that are often on our minds, especially that ever-present concern about aspiration risk in pregnant patients.
Indeed, aspiration risk. Given the anatomical and physiological changes in full-term pregnancy, the increased likelihood of reflux, aspiration pneumonitis, the review strongly recommends antacid prophylaxis, especially if you're considering general anesthesia. It's really about mitigating that risk.
A non-negotiable, really.
Absolutely. Almost a sigh of relief to see it strongly backed. Interestingly, bowel prep, which you see in some other ERAS protocols, not required for C-sections, and a core ERAS principle adapted here, minimizing fasting. The guidelines suggest avoiding solids starting 6 hours before, permitting clear fluids up to 2 hours before, but, and this is critical, the paper issues a caution. Even with appropriate fasting, a substantial proportion of pregnant women might still have significant residual gastric volumes. So continued vigilance from us is essential. It's a reminder that standard guidelines don't always fully capture the unique physiology of pregnancy.
That continued caution is absolutely key for us, as you say, given the physiology. Now, beyond preparation, what about optimizing existing maternal conditions? This seems like a broad but, well, profoundly crucial area.
It really is. Optimizing comorbidities, obesity, hypertension, diabetes, smoking, anemia, strongly recommended. Backed by high to moderate evidence. Now, physiological anemia is common in pregnancy. It doesn't always need correcting before surgery, but severe cases definitely warrant investigation for other causes, and transfusions might be considered. For us as anesthesiologists, we particularly need to be keenly aware of moderate to severe obesity. Because of the elevated risk of pregnancy complications, increased surgical complexity, and the challenges, frankly, for both regional and general anesthesia, it can dramatically impact our approach in the delivery room. This is where that meticulous preoperative assessment truly pays off.
Okay, so with the antenatal prep in place, our attention shifts to the intraoperative period, that critical window where, as anesthesiologists, our interventions are most direct, most immediate. What does this review emphasize about our wheelhouse during the procedure itself?
Right, this is where we truly shine in influencing ERAC outcomes. Prophylactic antibiotics within 60 minutes before surgery, strongly recommended, high evidence. The paper also mentions chlorhexidine skin prep. For us, the anesthetic technique is paramount. Regional is strongly recommended over general, and for multiple compelling reasons. It's associated with reduced blood loss, minimal neonatal drug transfer, a huge win for that dual focus, right?
Definitely.
It enables maternal consciousness during childbirth, which is incredibly important for the birthing experience, and also leads to a lower surgical stress response for the mother, plus less PONV, postoperative nausea and vomiting. The paper also points out that adding opioids to locals in regional anesthesia enhances the block quality intraoperatively and gives effective postoperative pain relief. Furthermore, combining regional with, say, a transversus abdominis plain block, a TAP block, that can further optimize pain management, both during and after. It's about building layers of pain control, you see.
Normothermia is always a hot topic in the OR, something we're constantly managing to prevent complications. What does this review specifically emphasize for C-sections?
Maintaining normothermia core temp above 36 degrees Celsius is a high-evidence, strong recommendation. And rightly so. Hypothermia is directly linked to increased intraoperative blood loss, higher transfusion rates, and an elevated risk of surgical site infections.
In longer stays too, right?
Exactly. It can prolong PCU stay and the overall hospital stay. The recommendations are clear. Keep the OR temp at 23 Celsius or higher, and actively use warming methods. That includes heat mattresses, forced air warmers, warming blankets, warmed fluid infusions, all things directly within our purview. And their impact is far-reaching, from infection prevention to PCU efficiency.
Okay, here's where it gets really interesting, connecting our work directly to neonatal outcomes. As you highlighted earlier, ERAC, unlike traditional ERS, has that unique dual focus on both mother and baby. What about practices immediately after delivery that specifically cater to that?
That's precisely the unique dual focus of ERAC, and it's what truly sets it apart. Delayed cord clamping, defined as clamping the cord at least 1 minute after delivery, moderate evidence, but a strong recommendation. Why? Significant, well-documented neonatal benefits. We're talking increased hemoglobin, reduced need for neonatal transfusion, improved neurodevelopment, and a decreased incidence of serious conditions like intraventricular hemorrhage, chronic lung disease, sepsis. Huge benefits.
Wow, yeah.
And then following that, facilitating immediate skin-to-skin contact once newborn stable, of course, also strongly recommended. This practice, shown to support breastfeeding success, significantly enhance maternal satisfaction, and reduce neonatal stress levels. These are vital early moments impacting both mother and child, and it requires our careful coordination to make sure it happens safely in the OR.
Right. Now let's transition to postoperative care. This is where the rubber meets the road for early recovery, isn't it? And our pain management strategies are absolutely central here. Yeah. What does ERAC advise for the mother's journey to recovery post-op?
Postoperative care is indeed crucial. Early mobilization, early discharge, it all hinges on this. Early oral intake is strongly recommended. Clear fluids can start once mom is stable after regional. And solid food can be introduced within just 1 to 2 hours post-procedure. The goal here is simple. Alleviate thirst and hunger, promote early ambulation, and ultimately reduce the length of hospital stay. And hopefully without increasing GI complications. It's a simple intervention, really, but with significant downstream effects on comfort and recovery speed.
And pain management. Always a priority after surgery, especially C-sections, given the incision and the need to get moving.
Absolutely. Multimodal analgesia. Using high-dose paracetamol and NSAIDs, that's a cornerstone of ERAC post-op pain management. The insight here is its direct role in reducing opioid-related side effects. Things like constipation, sedation, which, as we know, are notorious for derailing that early ambulation and bonding that's so vital. Oral opioids can then be used for breakthrough pain if needed, but the primary strategy aims to minimize them. And given the high incidence of PONV in C-section, patients report it as high as 80% sometimes.
Yeah, it's very common.
Combination prophylactic antiemetic regimens are also strongly recommended. Just to ensure patient comfort and facilitate that early oral intake and ambulation, it's about designing a pain strategy that actively supports the unique dual goals of ERC rather than just, masking pain.
What about those common, sometimes controversial postoperative practices, like
Yeah.
early catheter removal or VTE prophylaxis? How does the paper weigh in?
Okay, yeah. The paper discusses early removal of the urinary catheter. It's a strong recommendation, but interestingly, with low evidence, it acknowledges the concern we often have. With regional, there's that period where the mother might not feel the urge to void. So, concerns about urinary retention, neurogenic bladder, they're valid. However, many studies have reported that catheters might be unnecessary in C-sections. So, the controversy isn't definitively resolved there. For VAE prophylaxis, venous thromboembolism, standard pneumatic compression stockings are feasible, but routine heparin, generally not recommended. And it's important to note here, these VTE recommendations often rely on expert opinion or data extrapolated from non-pregnant patients. Data specifically limited to C-sections is lacking, which highlights another area ripe for future research, to really solidify our protocols.
Now, that's a sticky point for ERS, isn't it? Early mobilization. It's often the poster child of ERS protocols in general surgery.
Yeah.
So to hear it has very low supporting evidence and is described as tricky specifically for cesareans. That feels like a significant hurdle. What does this mean for our typical get them up and moving mindset, especially when regional plays such a big role? Are we sometimes setting unrealistic expectations?
You've hit on a critical challenge, really unique to ERSO. While early mobilization is a core ERS principle, it has, as you said, very low supporting evidence specifically for C-sections. Since most are done under regional, early ambulation within just a few hours, like you might aim for in other surgeries, isn't really feasible, not usually. Why? Residual motor effects of the anesthesia. Lower limb strength typically recovers within, say, 6 to 8 hours after spinal, but it varies. So yes, we might sometimes have to temper expectations. Or, more importantly, ensure robust assistance is crucial for those initial attempts at ambulation. Safety first, prevent falls, other accidents. The paper specifically points this out as a critical area needing more rigorous research. Research tailored to this unique patient population, exploring realistic timelines and safe ways to facilitate it. It's a prime example of where standard ERS principles meet the specific physiology and practicalities of our obstetric patients.
So bringing it all together, what does this deep dive into EROC mean for us now, and maybe more importantly, looking forward? This review really seems to hammer home that while ERC is gaining worldwide attention, there are still significant evidence gaps, particularly for interventions specific to pregnant women.
Precisely. Table 1 in the paper makes it strikingly clear. Many components, even those with strong recommendations, have very low to low levels of evidence specific to pregnant women. That's a clear call to action for us in the research community. Components like preoperative carbohydrate supplementation, postoperative chewing gum, that early mobilization we just talked about, discharge counseling, they currently have weak recommendation strengths and low evidence. This means they are prime candidates demanding rigorous, dedicated research in the cesarean population. We need to be the ones to build that evidence base, to move from just intuitive best practice to truly evidence-based protocols.
That's such an important question for us to consider in our own practices, isn't it? How much of what we do, even if it feels right, is truly evidence-based specifically for our obstetric patients? And beyond the evidence, what about the practicalities? Implementing ERAC protocols. How do these global principles meet local realities?
And that's the next major hurdle. Implementation rates for ERAC components, they vary significantly across different regions. The paper mentions Austria and Canada as examples. It specifically notes a lack of info on implementation in South Korea, highlighting the need to investigate the gap between recognition and actual application, and to identify the barriers.
Makes sense.
This is where cultural practices and local healthcare systems play a huge role. For instance, the paper touches on how the typical 3 to 5 day hospital stay in South Korea and the common use of postpartum care centers. Well, that influences recovery trajectories and the feasibility of ERAC components differently than in settings with a very rapid discharge.
Right, context matters.
Exactly. It suggests centers can selectively introduce ERAC components suitable for their specific circumstances. Acknowledging that a one-size-fits-all approach probably isn't practical. Ultimately, developing a truly systematic and successful ERSC protocol. It requires ongoing research, multidisciplinary collaboration, all to strengthen the evidence base and ensure it's adaptable. This isn't a static protocol. It really needs to evolve with new data and local insights.
This deep dive into ERAC really highlights how far we've come in optimizing patient recovery, but also, wow, how much more there is to learn, especially within this unique patient population. That unwavering focus on both mother and neonate truly sets it apart from other ERAS applications. It feels like a pioneering field in some ways.
Absolutely. The paper makes it clear. While ERIC programs have already shown improved maternal outcomes, reduced hospital stay, reduced opioid consumption, the strength of evidence for some key interventions is still limited. This just underscores the vital role of continued, targeted research, particularly for those C-section specific elements like intraoperative skin-to-skin, early breastfeeding initiation, things so crucial for bonding and early health. It's about refining what works best for this incredibly special patient diet.
And as anesthesiologists, we are literally at the forefront of implementing so many of these perioperative practices. Thinking about all these points, the evidence gaps, the implementation challenges, the cultural nuances, it really makes you wonder, how can we, in our own unique clinical environments and cultural contexts, not just adopt, but adapt ERAC principles? How can we strengthen the evidence base through our own practices and research to truly enhance recovery for mothers and their newborns? So the question for you listening is, what specific ERAC components do you feel warrant the most immediate rigorous research in your own setting?